we've got a big family here together in the room, and we get to know you people for a long time. Some of you have got tumours that might go on for a long time, some of them intermediate time, and some of them as well a short time, and that's the reality, and I can't do anything about that. But we can try to sort of improve the outcome as best as possible. I think getting it together as a national group with Galway and with Cork, that's the whole emphasis, is really to improve things and to improve survival and to improve your quality of life during that time as well. So we get to know you well, we become friends, and that's part of the whole journey. But it's really to emphasize that once you have groups like the NCCP underlining it and helping us out, that makes a huge difference to us every day. I'm not going to go through technical stuff, but just to remind people, and especially new people, because we've had now a few meetings together, and lots of you now know what neuroendocrine tumours are, or neoplasms, or cancers, and there's a wide variety of these, and they are malignancies, they're cancers. Some of them are very low-grade cancers. They come from these cells called the neuroendocrine cells, and they're dotted around the body. They can come from the lungs, from the stomach, from the duodenum, that's the first part of the GI tract here after the stomach, or the small bowel down here in the small bowel that's aiding digestion. Come from the colon and the rectum. It can also come from the pancreas here. So we've got a lot of different types of tumours, and many of you have got different types of tumours, and they all behave slightly differently. They all present slightly differently as well. So it's what we call a heterogeneous, or a very varied group. Some of them can cause specific symptoms, like the carcinoid syndrome that some people have, diarrhea and flushing that needs somatostatin analogues, and other types of hormone secretion can occur as well, and some tumours can just be found almost incidentally. We just stumble across them, like a little tumour in the stomach that can be very benign. So there's a big variety, and I always caution you all when you're looking up the internet, you should look up it. I think it's good to know about them, and if you have queries, you can address them through our group here, or through your group in Galway or in Cork, and through Lisa, and we can help you try to understand better. But suffice it to say, there is a large variety, and the outcomes are different. Most of these tumours, in fact, and most of you here have got things called sporadic tumours. So they just happen like that. We don't know. There may be some genetic or some alteration in your genetic profile that predisposes to that. And so they don't run in your family, all right? Some of you will have tumours, however, that fit into a specific familial type situation, like multiple endocrine neoplasia type 1, MEN1, and there are a few other rarer ones, and I'll mention that later on, but they pose, number one, specific diagnostic challenges, and also screening within your family, like your children, for example, or your brothers or your sisters, or even sometimes your parents, and I've seen that fairly recently, not later than last week. This slide just shows, this is coming from American data that's been gathered. It shows that the tumours, they're all increasing in frequency. Some of them slightly less than others, but if you take the lung, for example, that's going up, the appendix, stomach, small intestine, they're all going up. And we can say now that if you have 100,000 people in a rugby field down in Aviva Stadium, you can say that 5.25, now the 2.5, I don't know where you get the quarter, but that's the statistic. About 5 out of those 100,000 people will have a neuroendocrine tumour. The incidence also has increased in Europe, and these are sort of a slide that I put together from data coming from Norway, from France, from the UK. You can also say, what about Ireland? So we have data now, and thanks to the National Cancer Registry, also linked in with Jerome Coffey's NCCP group, very close cooperation, and we've been lucky to get some data from them. This is data from all subtypes combined, but this is only what we call invasive, all right? I'm not going to go into the definition, but we have sometimes very small tumours that are benign, they're not malignant, but they have a malignant potential. They could become invasive one day, and these ones are only the ones that are defined as being invasive or malignant between 1994 and 2010. And we can see that for males and females, first of all, that the incidence is increasing. That's important for us to know that, very important. And also that if we look at, and again fit up that football field, 100,000 people, 4.6 of the Irish population will have a neuroendocrine tumour. Now that's very close to the EUS is called SEER data, very good quality data. So this also shows us that we are in fact providing good data, and I'm grateful to the National Cancer Registry for this. We're going to try to improve on this a bit more because we'd like also to have the benign figure patients included into that. And very briefly then, if you look at, this just shows upper gastrointestinal ones from the stomach, let's say the duodenum, or from the esophagus, the pancreas and the small intestine in 3 different colours. They're all increasing again. It's important to look. What about then, I said that many of you our patients or your relatives live for a long time, some a little bit less, but fortunately most people do well. And if we look at a thing called the prevalence, so how many people are alive and living with the disease, then this is important. And even though it's a rare disease, there are quite a few of us around. And if you come to our clinics, you'll see the clinics are bigger and bigger, and the number of patients we discuss, for example, at our multidisciplinary meetings are quite a lot. So it is a real problem, and there's quite a few patients alive with the disease that need input and help. This is not, but an estimated 17-year prevalence of 830. I think we've got to go back and work on that figure, but we do have data from the National Cancer Registry as well, so supporting that the prevalence in this country is rather high. One of the problems, again for some of you newer patients to this arena, is that you've had symptoms going on for some time. It delays the diagnosis, like many cancers, and you're not alone in that field. And the symptoms can be very non-specific, and that's one of the problems. And that's also something that we're trying to do as part of the structure, to train not only the junior doctors, but also go back into the community to train the specialist endocrinologists or the gastroenterologists or the oncologists, but the GPs as well, to try to recognize the symptoms a little bit earlier. I look at data here, and we do have some early data. I think we're probably a couple of years outside what would be, for example, Don Granberg from Sweden, or from the Netherlands. They're diagnosing a bit earlier. In France, a little bit less earlier than, let's say, in Sweden and the Netherlands. And in other countries in Western Europe, we're about the same. So we're missing the boat just as badly, or they're missing the boat just as badly as us. But we've got a little bit of work to do on that, and that's purely got to do with education and awareness. This is an interesting slide, actually. This is what a number of international experts looking after your tumours found, that this is what happens. So when you get a little tumour, this is time 0, and you go through a number of years, you see all of this early bracket, and even when you've got what we call metastatic disease or more advanced malignant disease, you're still in this vague symptom profile. So that's where we're missing out. Then you get, let's say, if you've got carcinoid syndrome, a tumour of the small bowel secreting substances that causes this flushing and diarrhea. This is where we're getting it. Look at how long it's been growing for, 10 to 14 years. It's amazing. So if we can bring this back here, we'll do better. We'll do better for you. With a much better outcome. This has also been shown and backed up by a publication from a group from Boston, in the Dana-Faber group. They're a nice group, and they've got lots of patients. If you look at patients with small bowel tumours, this is the time to diagnose to the specific symptoms leading to diagnosis, and you can see that it's quite a long time, especially for patients with these small bowel tumours. But also pancreatic, and some outliers here up to 100 months. That's 10 years or close to it. And again, for other ones as well. So it's quite long. So unfortunately, some of these tumours, in fact, don't speak to us early enough in a specific way. So it's very non-specific. Half of patients have what we call a specific syndrome. A tumour of the pancreas that secretes either a thing called gastrin, causing ulcers and diarrhea, or insulinomas and various other things. Only 1/3 or a little less of patients with the tumours coming from the small intestine, or the midgut as we call them, have the specific carcinoid syndrome. So lots of patients don't. And what happens then is they wonder, why wasn't I diagnosed earlier? Sometimes they come because they've got lesions in the liver, and we've got to address that as well. I mentioned the word incidental, patients who've got no symptoms. We stumble upon them more and more, and they're important ones to deal with as well, very often in the pancreas. They can be small, but we also find them in the stomach, in the rectum, in the lung, and in the duodenum. And also data from the NCP, up about 10% of even ones that are more advanced or malignant can present in an incidental way. This is just a spectrum. I won't go through this, but just to show you again that we have got very good now data over the last 10 years looking for patients, in fact, who present with at different stages. It's about sort of, I would say, a quarter in each sort of group in terms of how advanced or how non-advanced, let's say, your disease stage is. So we're dealing with a spectrum of problems. So some of you, it's important to know, have got very, very, very indolent, slow-growing, benign tumours, maybe with no potential to have malignancy, and some of you present initially with a malignant disease and more advanced, and that makes up part of the, I suppose, the spectrum and the variety of patients that we see. This is also just to share with you and with Jerome as well, because this is interesting data to look at. These is tumor-directed surgery or chemotherapy in the same period of time collected by the registry. And these are a variety of neuroendocrine tumours. The top ones are the ones that we mostly deal with, but we can see that surgery is fairly frequent. 80% for small intestinal tumours. Pancreas about 35%. Colorectal, you can see this. Chemotherapy here, that's probably pretty good, the surgery, I would say. We're probably falling down in a little bit, but I think over the last 4 years we've been more aggressive, and I think that's important. Here in the chemotherapy, we're pretty low, in fact. So these data in the red here, shows me that patients are being undertreated, okay? And we are more and more aggressive now with the type of treatments, and fortunately, we have more and more treatments available to us as well. Chemotherapy, there's lots of different types of chemotherapy, and I suppose these are just sort of overall gross figures, and getting in and trying to sort of prise open that data a bit more would be important to do as well. Jerome earlier mentioned about this multidisciplinary management strategy, and this is very important. It's important for a number of reasons, because we can't deal with these things on our own. I mentioned that surgery is important. Sometimes then you have to go on somatostatin analogues, and there are many, many types of treatment, and this will be gone through with a little bit later, and especially Dan Granberg. But if we just look, and this is interesting as well, this is the median survival time of patients, okay? Now, it's not a direct comparison of data over 2 periods of time. It's just getting crude figures from different centres. So this is from a database, right? So we've got a 40% median survival in terms of months here, 40 months here, and a bit less in this sort of large group in the States. And if you look at Uppsala, right, Dan is from there, and if you look at the Moffitt Center, that's in Tampa in Florida, look at the survival, more than double in multidisciplinary groups. So that's really striking. This led me and Donal and Justin and a number of other groups with Susan to get together and set up this Irish neuroendocrine neoplasm group. Derek was there from Cork, and we had Greg Leonard from Galway, and quite a few people who were interested in developing a more systemic approach and more sort of focused group back in November 2012 to neuroendocrine tumours. And that also coincided, correct me if I'm wrong, with the first patient group meeting, which was a great success, and a lot of people turned up, and we held it down it was a public forum down in Trinity, and it was a great day. But this is what really we want to try to achieve, sort of real expertise in helping you out in terms of getting the best fit of therapy, which you can see can be very, very varied. And this is only just a small smattering of the common treatments that we use. You know, hormone therapy, peptide-related therapy that sometimes we ask Dan to be involved with, or the people in Rotterdam. We could taste therapy, sometimes directed therapy going to your liver with injection of special materials into your liver, targeted chemotherapy, everolimus or Afinitor, normal chemotherapy many, many times, and symptom relief. And on top of that, then, we've got lots of other specialists who are involved, palliative care teams sometimes, and pain control, many, many things. So you can see it's a big loop, and it's not a simple circle, okay? And there are many ways of getting in and out of that. So that really defines the need for a real team. And this Centre of Excellence initiative I'm part of this as part of the European Neuroendocrine Tumour Group, and there's been a very sophisticated development of getting all of those experts together in a very controlled and rigorous way to create these specialist centres. Here we are in Norway, Denmark, quite a few in the UK already, a couple in France, Germany, Italy. Now there's more going on. Poland are getting one or two going through, and hopefully this one here is going to be filtering in soon, hopefully, to Dublin. And with your help, we're going to look at perhaps seeking Centre of Excellence accreditation in Europe. Our CEO here in Vincent's with Margaret have approved us going forward for that. We have to get buy-in from these people, right? The gastroenterologist is fine, I've signed up. The endocrinologist is fine, the surgeon's fine, Justin is down there, we've signed up, and the oncologist as well. We've got nuclear medicine, pathologists, radiologists, and look at this, laboratory, genetics, anesthetics, pain. Then you've got the GP. We also have our partners in Cork, Derek and his group, Chris and Adrian, and we've got the group in Galway. So if we can get momentum to go and do that, what happens is that we have external auditors come in and they examine what we're doing. They'll examine our patient records. They'll sort of say, are you doing this right? And they will see if we can achieve a level that would be fit to become a European Centre of Excellence. Now, it might be next year, it might be the year after, but we're very close to doing that. Our structure in this country then has changed because with our close cooperation between the three main centres, we've developed now, more than a skeleton of a national service, where we've got dedicated multidisciplinary team meetings. In Vincent's every 2 weeks. Derek can let you know about Cork in a little while. We see between 20 and 24 patients every 2 weeks. Where we've got an hour and a half to go through things. It's extremely well prepared, thankfully, for Lisa. Colin here is preparing this, and we've got a net multidisciplinary clinic every week. Remember I mentioned about the hereditary tumours. Sometimes you've got hereditary tumours and multiple endocrine neoplasias. You've got little parathyroid tumours. They're benign tumours, but they secrete calcium. And sometimes we need to get those little tumours out of the parathyroids, just beside the thyroid gland. And the girl, Ruth Pritchard, who looks after those little adenomas in the parathyroids, well, she's got the clinic next door, and she just pops in to see those patients on the day, which she did yesterday as well. And that's just absolutely invaluable, okay? We can have the pathologist with us, and I have to thank my colleagues who've really bought into that, because it means an awful lot. It doesn't matter if you're coming from, Glenageary or from Malahide or from Donegal, but especially from those who are coming outside of Dublin, if we can get a coordinated consultation from various experts, that's really proven and valuable. And I've had a lot of positive feedback from the patients on that. But it's not to me, it's to thank my colleagues for their availability. We're about 120 new patients per year, probably a bit more. We also have now in discussion with a genetics expert in the Mater, a very nice guy who's a gastrointestinal oncologist, helping us out with these hereditary related neuroendocrine tumour disorders like the ones I mentioned. There are a few of them, and with that we need real expertise for the gastroenterology problems of that, the tumour problems. We have the surgeon, etc. But also these parathyroids, we have other adrenal gland tumours that can be very complex. And I'll mention that again. Mercy University Hospital in Cork. I was invited down not so long ago to one of the multidisciplinary meetings down there, and I think they're doing excellent work, really, really good work with a number of experts in the field, and really, really great for their work. And the same in Galway University Hospital. Also mentioned the treatment abroad scheme. Now, not everybody, and I think it's important, not everybody, even people with advanced tumours, you don't all have to go for peptide receptor therapy. Sometimes it is necessary, especially for the ones that are coming from the small bowel, and to go to places like Uppsala. That's our main partner in terms of treating that, and Dan Granberg is going to talk after me. We're really grateful to Dan, Rosetta, and all of the team there for being so available, so kind, and so responsive to our requests. We bug you a lot, but you've done great work, and we're really thankful for that. We also work with the people in Rotterdam, Dick Quackenboom and his group, a little bit less so. When we send people abroad, there was 15 in 2013. Catherine Donoghue in the HSC, thank you very much for providing these data. And up until, I suppose, a couple of months ago, there was about 11 patients. So it seems to be fairly steady state. Should we have this type of treatment available in Ireland? It's expensive. You need special things like cyclotrons and fancy equipment, and our CEO knows about this because we're trying to get a cyclotron in St. Vincent's University Hospital with the University College Dublin for other reasons as well. It's work in progress, and I think down the road it will probably happen, but not straight away. So for the moment, I think it's probably cost effective to do that with proper partners who are very good at doing it. So just to highlight that and to thank the people involved in that as well. So I'm just like to wrap up then with a few further developments. So again, Keelan McGrain this year provided us with a dedicated specialist registrar. So this is important because we're training the younger partners, right? I've gone above the 40-year bracket now, well above it. We need to bring in partners, younger partners, to do this for the future. This person, Chun Shen Lee, who is here, is a gastroenterologist, but a very dedicated interest in this, provides a close link between, let's say, the more senior team, but between the surgeons, between the endocrinologists, between the nurse specialists, and it really helps in our inpatient service. My time is split between St. James's Hospital and here. I'm not always here as an inpatient, and Donald, for example, is in Loughlinstown as well. So it's really vital that we've got quality, not just young, but an advanced person like Chen Xiang. It might be an endocrinologist or whatever. It might be a surgeon, but we want to try to have that person there, and that's really proved invaluable. And it also helps. We've had a couple of clinical trials. We've got more clinical trials on the way, hopefully. And this person could be very valuable in terms of linking for clinical trials and a coordinator as well. I mentioned about this application for European Centre of Excellence accreditation. We have approval from the hospital. What does this do? The whole objective is to improve standards. We need buy-in with all the multidisciplinary partners and the hospitals. We would aim to have a hub in St. Vincent University and also affiliated partners in Cork and Galway. And I think, and I've mentioned it to Derek, but I'd hope that I know that Derek and Adrian, for example, and Greg and Marcia, I think that if they're over for if we have people over for an audit, that you would come and share in the group as affiliated partners. I think that's very important. That's part of the structure. What this provides really is external audited analysis of structure. Jerome Coffey mentioned that. That's invaluable. So somebody from outside comes in and sort of looks at what you're doing and sort of says, look at, we spoke about, or Jerome spoke about KPIs, and all that is that, how fast are you going from your GP or your oncologist to be seen by a specialist, the specialist that you want to see? How fast is your Octria scan being done, your CT scan being done, your bloods and all of that? And I tell you, we've got to put up our socks a lot, and I'll mention that in a moment. And of course, it also provides then internal or inter-centre of excellence exchange. So you saw all of those dots on the map of Europe, and sharing data, participating in clinical trials, opening up clinical trials that are relevant to all of you here. That's what it provides as well. More patients are being referred to the centres. We've had close cooperation between our centres. It's also facilitated, and the interaction with all of you here today has helped us. Terry, thank you. You've helped out in this, streamlining the treatment abroad. I think we've got a little bit more to do in that, and you're going to work out the pathway because I'm extremely grateful to you. That's been absolutely vital. We need to improve this net-related blood test and tumour mark analysis. Mark, I like the concept of patients coming in with this, a card or an app on your phone or whatever it is, sort of saying that I'd love to, and Lisa, we were talking about this yesterday, so if you come for your scan, on that day you have your blood test done, you come then, we're discussing the MDT, and yesterday it was so bad. I mean, the 4 or 5 patients that I saw, we saw about 10 or 11 yesterday, chromogranin A wasn't ready, some of it wasn't done, urine, it's very cumbersome. By the way, we may have a new test for this urinary test that would be replaced by a blood test, which would simplify it. In terms of these testing and even genetic testing and all of these specific neuroendocrine tumor blood testing, we're very fortunate to have a new head of the biochemistry that Donald knows very well too. It's just really started, I think, and we're meeting with that individual to try to, number one, make sure that all the tests are the best tests available and we can streamline them, okay? Tests from Galway and Cork, I don't know where they're going to, okay? If we've got 3 centres, eventually I would hope that all of the patients are coming to those 3 centres and we can just sort of say, right, this is a very expensive test to set up. Well, the guys have it in Cork, we'll send our stuff to Cork for that. And all the rest of it's coming. But we know where it is and it's done in a unified way, okay? And there are many other blood tests that are complex, that are sent abroad. They could go to Belfast, to Birmingham. We've got a lot of work to do in that, okay? And we're not ignoring it. PRT, I mentioned that, and Daniel mentioned that perhaps earlier. Should it be available in Ireland? I don't think so for the moment, is my personal view, but we need to have good access to it. What about other imaging procedures? And some of you, as Mark mentioned, kindly donated some money to the net fund that we've established here in the St. Vincent's Foundation. Gallium PET-CT, for example. This is like an octreoscan scan. It's a bit more sensitive, a good bit more sensitive actually. And we have the possibility of doing that. We have the possibility of doing it in Cork or in Galway or in another hospital. I'm really convinced, and I'm going to fight on this one hard, that we need gallium PET-CT in St. Vincent's Hospital as the national centre. Now, where am I looking? Which direction am I looking? And we've had, well, I'm looking at both of you. You have to have a PET-CT for this, okay? And St. Vincent's, there are quite a few PET-CTs in Dublin. One of them is St. James's Hospital. I know that in St. James's Hospital that they would provide this for me within 2 months if I asked them. We've done the business plan. You can make money for the hospital. We know we can make a bit of money for the hospital, and we can also provide an excellent service, because every single one of you patients who would have now a neuroendocrine tumor, we're going to do what thing called a staging or sometimes follow-up, we'd replace the octreoscan scan, which is cumbersome. You come day 1, sometimes day 2, and even day 3 sometimes, because the images, it's complex, okay, and it takes a lot of time. And we'd replace this by simple PET-CT gallium. It's just a little tracer we give. But we can do that. Well, we're working on that as well, because we want that here. But we don't, it's going to be more complex to send patients to the Mater or to James's to get gallium PET-CT. And there's been a lot of work behind the scenes to get PET-CT here. We think that we could probably, you guys are not going to be happy on that, but I'd like your opinion on it later as well. I mean, if you're going to fund it, and but maybe we could have it in Cork, and you could go down to Cork, you'd be well treated. Every time we go down there, we're well treated. But look, we've got to come up with a plan for that. Adrian and I spoke about that as well. We have to get it sorted. What about other, this is my last slide, other initiatives then outside of just say the Dublin group and the Cork group and our own national group? There have been clinical trials, and a very important clinical trial recently. There was the Clarinet trial. This was sponsored and run by Ipsen and our colleagues in the UK and in France mainly. This was the somatostatin analogue, lanreotide. It's been shown to be a good treatment for pancreatic tumours. Not only pancreatic tumours, but small intestinal tumours. We knew that was the case for sandostatin already. That was published in the New England Journal of Medicine, our best clinical paper, a phase 3. That's a very robust trial, very recently. And they're looking for the license for that. Some of you are on that for that purpose. So that reinforces our understanding and sort of suspicion that it was useful. And now we can prescribe it with far more confidence as well, these type of agents for patients with specific tumours like pancreatic neuroendocrine tumours. Again, not for everybody, but it's very useful. There's an international trial called the AAA trial of peptide receptor radionuclide therapy. That's the lutetium that some of you might have had, for example, with Dan and his team over in octreotide versus high-dose octreotide. That's ongoing, and it's a very important trial because it's the first phase 3 trial in this area. And there's a lot of trials going on to determine which ones to start with, and Derek will talk about this, but especially for pancreatic tumours, which treatment should we start with? We've got a lot of different treatments available to us now, and we want to sort of define sometimes which is the best one to start with. Last week, I was in Vienna for a meeting on Thursday and Friday, and we spent a whole 2 days, group of international experts, 60 experts from all around the world, updating the international guidelines for the European group. Very important. It's a lot of work. I chair the group actually, but I think it's very important. And we're going to have now very soon, hopefully by March of next year, updated algorithms or flow charts on the internet site, and they'll be available to you as well on the internet. So that's sort of just there's many other things going on, but it's just a few of the important ones I felt. And I would just finally like to thank the team members of the IrishNet group in St. Vincent, especially Lisa, who's really does amazing work. She's only there on Thursday and Friday. I don't know how she does it, but she gets all of that done. You'll meet Lisa in a more informal group later on. I'd also just like to reiterate my thanks to our partners in Cork and Galway. The international partners, Dan and Roselda, you're extremely welcome again. It's always great when you're here. And other people as well. And we've had many other international experts where we've asked for opinions, and patients have gone to see, etc., to try to help us out in deciding the best line of therapy and how we've managed patients. HSE Treatment Abroad Group, very, very important. And then to the National Cancer Control Programme, but I'm really representing that group, as I already mentioned. And then to the Patient Network for the close liaison that we've had and for the very productive interactions. Thank you very much.